If you have back or sciatic pain, welcome. You're in the right place, and I really hope you're going to get the answers that you're looking for. And I believe I have those answers, a lot of them anyway. So welcome. My name's Rick Olderman. I'm a physical therapist, and we're going to get going. So tonight, what we're going to learn is three primary things. The first secret to fixing back and sciatic pain is that there are two primary patterns behind most back and sciatic pain. So I want to tell you what those are, and then we're going to test you to see if you have these happening in your body. So you should leave this talk tonight knowing what's going on with you and why. Okay, and so the secret number two gets into the test to understand whether these are happening to you. And then the third thing, I kind of changed this up a little bit. I get so many questions about leg length discrepancies. And so I just decided I'm going to address that in this talk tonight so that you all understand leg length discrepancies, what's going on here. Hopefully I'll blow a lot of your minds. So I hope this information is new for everyone and that you get a lot out of this. So let's get started. So again, I'm a physical therapist since 1996. And I'm a HANA somatics practitioner and Pilates instructor. I'm a personal trainer. I'm certified in therapeutic dry needling. I've owned a sports and orthopedic clinic here in Denver for 10 years. I just sold the clinic about a month and a half ago. So I'm now trying to turn the world into my clinic instead of just that tiny little space in my building, so I can help more people now. So that's me. I've written 6 books. They're all for sale on Amazon. They sell quite well. I speak at conventions and all sorts of seminars and symposiums and so forth. This picture that you see here was kind of funny. I was speaking at this National Health and Safety Symposium. They got me in at the last minute, and it ended up that I had the highest attended talks. I spoke on back pain, which is why you're here, and then also neck pain and headaches. Both of them were sold out, standing room only. And it wasn't at all, it didn't have to do with me being any kind of celebrity speaker or anything like this. It's that all of these people are just like you who have pain and no one's been able to help them. And so you can barely see in the middle of that room, I have a table, and I demonstrate what I'm talking about and show how it solves pain right there in front of people and take pain away. So that's what I'm hoping I can do with you tonight, is take some of your pain away, help you understand why you're having it, and start turning this ship around a little bit. Okay, so how do I specifically solve back and sciatic pain? Well, let's get down right down to it. So this gets into the first secret. There are two primary patterns behind almost all back and sciatic pain. So I want to talk to you a little bit about how I got this information, because that matters. I didn't just come up with this out of the blue. All right. There are 3 patterns of problems causing back and sciatic pain. These were identified by 3 independent researchers at 3 different periods of time in 3 different areas of research. So the first was Dr. Shirley Sahrmann. She's a PhD PT lecturer out of University of Washington in St. Louis. Her focus was on movement impairments and biomechanics. And she found that there are 3 primary movement pattern dysfunctions that are occurring that cause almost all back and sciatic pain. Then there's Thomas Myers, who researches in fascia. And so he wrote a book called Anatomy Trains, which is fascinating. And fascia is connective tissue in the body. It's what holds us together. It holds our viscera in place. It keeps our skin attached to our muscles. It attaches muscles to bones. It holds our brain in place, blood vessels, nervous system, everything. And he identified that there are superhighways of fascia that run from the top of our head down to the bottom of our feet. And lo and behold, 3 of these superhighways of fascia correspond exactly to what Dr. Shirley Sahrmann found in terms of a movement impairment dysfunction. And then the third researcher was Thomas Hanna. He's a PhD who focused on neurology of the body. And his big thing was understanding primal reflexes in the body and if those had anything to do with pain. And he found that there were 3 primary neurological reflex patterns in the body that are occurring that contribute to back and sciatic pain. All 3 of these people had no idea of the other. of the other two. And they all pointed to the same three patterns that are occurring in each of their respective fields. And when you see something like that, you know you're onto something. So I started putting all this together and integrating it all together. And that's what I've been using in my clinic to go deeper into any type of patient that walked in my door was looked at like this and their pain was solved. And I've trained my other therapists to do this too. So this is where this information is coming from. So it's not just something that I came up with out of my head. This is based on real solid research. So here we go. It's just that no one's put it together before. And I think it's really important. Okay, so what's the first pattern that we're talking about? Well, it's called an extension pattern. And I'm just going to take my screen down a little bit here so you can see this. So if you see in this drawing here, you can see this big arch in the back here. And then you see this long belly. And then you can see that the pelvis is tilted forward. This is called a lordotic posture. Now, this woman has this posture. You may know people, you may be one of the people yourself who has a posture like this. Typically a really arched spine, you'll see a distended belly, and then tight thigh muscles or an anterior tilt like this. All right. You can see how that's much different. This is called a sway back posture. I call that a mopey teenager posture. And basically this is just a mopey person who's just kind of sitting on their, they're just kind of just hanging out there. There's no muscular activity holding them together, doing anything. So they're just sitting on their vertebrae. So both of these two patterns fall into an extension problem pattern, which basically means that they've got too much arch in their back. All right. And we're going to test this on you. All right. So in just a minute here. So hold on. Here we go. Pretty soon. All right. So the second pattern that we're going to talk about tonight is something called a side bending pattern or a side bending problem. And so what that means, if you look at this picture here, you'll see one side of the pelvis is higher than the other. All right. You'll also barely see that this rib cage is lower than this side. So there's a crunching going on there on that left side there. And so this is what causes a different type of problem. And in a real person, here's what it looks like. I mean, this person's a mess. Look at this. I nearly fell over when she walked in my door and I had to treat her. But there's so much going on here. But one of the big things is you can see this massive crease here, almost no crease on this side. Same on this person. Big crease, almost no crease. You can see elevated pelvis, pelvis is down. You can't see that the rib cage is down, but it's down because that's what's creating the crease, that and the raised pelvis. Same on this side. You can see her pelvis on this side is higher than this side. So that's creating the side bending problem. So we're going to see if this is happening with you tonight as well. Okay. All right. So we're going to go back up to the big picture. All right, so the extension problem and the side bending problem I find are behind 99.9% of almost all back and sciatic pain. And so that's, again, what we're going to be testing in you to see if you have this too. I almost guarantee that if you're watching me tonight, it's because you have one or both of these two patterns. Okay, so here we go. Secret 2 is 3 tests to understand your back and sciatic pain. Here's the first test. And I really, everyone, please do these tests. I want you to do them right now, tonight, okay? Right this moment. So the first one you're going to do is you're going to lie down on your back on the floor. So you can be on the floor, you can be on the couch, you can be on your bed, you can be on your dining room table, you can be on your kitchen countertop. But I want your legs to be straight when you're lying on your back. So go ahead and get into that position right now. You can still hear me, even though you're in that position. I'm not going to do anything wacky up here in the video. So just go ahead and lie down on the floor with your legs straight. All right. We're only going to be here for maybe 30 seconds or a minute. So let's assume that you're lying down right now and you're on your back. And I want you to feel how your back feels in this position. Is it uncomfortable? Does it feel really comfortable? Do you feel tension there? Does it feel relaxed? All right. So that's the first part of this test. Now, the second part, after you've lied down with your legs straight and you can feel what your back feels like with your legs straight, now I want you to bend your knees. And you can put your feet flat on the floor if you like, or you can even hug your knees to your chest. It doesn't matter. Either way, whatever feels better for you. Now, what you're doing is you're comparing whether your back feels better with your knees bent or with your legs straight. And if you're not sure, then straighten your legs again and see if your back feels as comfortable with your legs straight as it did with your knees bent. All right, simple test, but it shows a fundamental issue that may be happening with your back. Okay. All right. So hopefully you have an idea there. Now stay on your back for just a second longer. I want you to notice with your legs straight again, you can even put your hand underneath your low back, but I want you to feel how much arch is in your low back. Can you feel that back is arched a little bit more when your legs are straight, when you're lying on your back? And now when you bend your knees or hug them to your chest, can you feel that your back is flatter against the floor? All right. That's important for you to get that all we're doing is changing the amount of arch in your back, legs straight or knees bent. All right. Legs straight, more arch, knees bent, less arch. Okay. You can stand up and have a seat in your chairs again. Thank you everyone for doing that. It's a really important test and it's going to, why are we even doing this? Well, most of you probably, can you raise your hands if you felt that your back felt better with your knees bent? All right. Almost everyone, if you could see everyone on this video, you would see just about everyone's hands are up right now. And that's because of, this goes back to that extension problem that I showed you earlier, that you have too much arch in your back. It's as simple as that. Okay. And we'll go a little bit more deeply into that if you like, but let's move on to the next one. All right. So what does an extension problem mean? All right. So here's where I'm going to ask you to really change the way that you've been taught about what's going on with your back. Many of you have had x-rays or MRIs that show that you have stenosis, spondylolisthesis, disc bulges, degenerative disc issues, facet joint issues, arthritic spines, and so forth. But all of those, and I can almost guarantee that everyone listening to me right now has been diagnosed with one or two of these things. Yet all of these diagnoses, their backs will feel better when their back is flatter, when they're lying on their back and their knees are bent. All right. So what that's telling you is that if your back feels better when your knees are bent, you've got too much arch in your back occurring too often. And what that's doing is it's putting a strain on your back. So even though you may have all of these physical issues, they are not the cause necessarily of your back, because they were still there when you were lying on your back and your knees were bent and your back felt better, right? We didn't change the degree of stenosis or the spondylolisthesis or how much disc bulging you had. What we're changing are the forces acting on those things. And that's the beauty of this system, is that if we just eliminate those forces, regardless of what diagnosis you have, your back will feel better. I hope that makes sense. So all of you who felt better with your knees bent, it means that you have an extension problem or too much arch in your back. If you do nothing else other than the next few days, stop your back from arching, your back will start to feel a lot better. But we also have to target the things that are pulling that into an arch. Okay. And we'll talk about those in a little bit. Okay. So here's the second test. Does your back look like this? All right. So you can see if you look at, especially this guy in the middle and the one off to the right a little bit, they have a crease on one side of their back and they don't have one on the other. If you look at all of those pictures, you'll see a crease more prominent on one side than the other. All right. How do we test this on ourselves? Well, you just do a selfie with your back to the camera. So what I'd like you to do, if you can do it now, if you have someone in the room or house with you who can take a picture of you, great. And if not, just set up your phone, put on a timer, walk away from it and keep your back to it. But make sure that you can see your waist and mid-back area so that we can see whether you have a crease on one side or the other. It's a really simple test. So you wouldn't believe, none of these people realized that they had a crease on one side of their back versus the other. And what I often do in the clinic, because people don't believe me when I tell them that this is happening, I'll just take a picture on their phone and show them so they have it on their phone And it proves to them, they're just like, oh my gosh, I can't believe this is happening. And I never knew it. And more than that, no one ever told them before. And it's one of the first things to look for when you're dealing with some kind of back or sciatic issue, SI joint pain, any kind of unilateral pain in the body. All right. And this is so easily corrected. All right. So that's the test number 2. Does your back look like this? All right. Do you have a crease on one side or the other? You don't have to show me or tell me, but hopefully you do this test. Okay. It's important. All right. So what is this telling us? Well, if you have a larger crease on one side than the other, it's telling us that one side of your pelvis is higher than the other, and that one side of your rib cage is lower than the other. And this is responsible for unilateral problems like, left or right sciatica, left or right SI joint pain, left or right low back pain, left or right facet joint issues, left or right disc bulges, and scoliosis types of issues too. Yes, this is a pattern of scoliosis. So scoliosis, when you read, if you've had an MRI of your back and it says scoliosis, curve, it doesn't mean that you have a congenital or true scoliosis. Scoliosis is the term medicine gives to a spine that's curved sideways. It could be for any reason. It could be because of poor function, or it could be you were born that way. Most of the scoliosis that we see, we can change, even if people were born with it, because a lot of it has to do with function. So anyway, if you have this pattern and you have unilateral pain, if we can get rid of this pattern, normally, then we get rid of that unilateral pain. It has a lot to do with usually sciatic and SI joint dysfunction. It kind of makes intuitive sense, doesn't it? Doesn't it make sense that if you have more compression on one side of your back, that you would have more pain on that side? Okay, so here we go. So this woman, real patient, came in. Her back pain was 90% reduced in 7 visits. Did I change how she looked? No. What I changed were the forces causing her body to be shaped like this. And we eliminated or decreased many of those forces. And even though she still looked very similar to this, she had no pain or almost no pain. All right. So so you may fix that SI joint pain or that sciatic pain, and you may still have that crease, but what you've changed are the forces that are causing the crease. All right. The crease may go away someday, but that's not important. Immediately, really what's important is that your pain goes away. That's what I care about. All right. Let's look at test number 3. This is a biggie. All right. So we're going to do a little bit of walking. And so what I'd like you to do, I'm going to back up here and I'm going to show you, move my camera down. So what I want you to do is I'm going to have you put your hands on your butt. I don't want your hands down here. I don't want your hands up here. I want your hands right in the center of the butt. And I want you to pinch those butt cheeks together. I want you to do this right now. So I'm not the only one embarrassing myself on camera here. All right, so we're going to pinch the butt cheeks together, and you're going to get a sense of how much contraction you feel your butt cheeks can achieve. That's your maximum contraction. And now you're going to relax that contraction completely. Just let it all go. And now walk around the room for about 10 steps. And keep your hands on your butt, though, when you're doing that. And what I want you to notice is your butt contracting at all when you're walking? Does anything like that contraction occur when you're walking around? Keep your hands on both of your butt cheeks while you're doing this. All right. Remember, this is also going to YouTube, so you might want to walk off camera. All right. So hopefully after 10 or 15 steps, you can find, most of you will probably find that you had very little butt muscle activity going on while you're walking. The butt is critical to how our pelvis and spine work. And if the butt isn't turning on well while you're walking, then you're missing a primary positioning and stabilizing force in your walking pattern, and how you bend over, how you stand up from a chair, how you sit down in a chair, all that kind of stuff. So this is a critical thing to understand, that, oh, I thought I knew how to walk, and now I find out that I'm not really walking that well. Well, stand in line, because everybody who comes to our clinic with back pain on down to foot pain, we teach them all how to walk better, because that is one of the primary fundamental issues that's causing all of the pain in their body. Once they learn how to walk better, it stabilizes everything. It turns certain muscles on, and just as importantly, it helps turn certain muscles off if you walk correctly. All right. So this came into play. Carol came in with, she was a collegiate swimmer, Division I school, had a scholarship to go swimming. After 2 years, developed back pain. It's a Division I school. She had a scholarship. She had every available medical professional to help her with this. No one could solve her back pain. She ended up losing her scholarship because she had to get out of swimming, and her back pain never went away. She came in 15 years later into our clinic. She was in so much pain, I couldn't even touch her. And she didn't even come for her back pain. She came for a foot problem because she had completely given up on her back pain. And she was in so much pain, I asked her to sit down, and it took her a minute just to compose herself. After sitting down, it would rack her with pain. And then same with, if I stood up, she would have to hold on to something and wait till the waves of her pain would stop. I couldn't even perform an exam on her. But fortunately, because I understand how things work as a system, I saw all I needed to see with her just walking to my table. And after just our one visit where I didn't even lay a hand on her, I just changed how she was walking. 75% of her back pain was gone after 15 years of agonizing back pain. And her plantar fasciitis was also 75% better. All right. And this is the beauty of looking at the body as a system, is that simple solutions have huge ripple effects in the body. And so things like this are not uncommon, okay? Because we understand how it all fits together. Okay, so a lot of you might be thinking, why haven't I heard this before? Because in medicine, I fall into this category too. I was not trained to think this way in school or in any of my CEU courses afterwards. What we are trained to think is to look at the body as a component system. So we're trained to look at the spine and see if the vertebrae are rotated or side bent. We're trained to look at the pelvis to see if there's a nutation or counter nutation or an upslip or a downslip. And so we fix those things, or we dry needle them, or we shoot them with cortisone, or we operate on them to fix whatever anomaly we see. But the manifestation of those things, those are not the problems. They're a manifestation of a larger systemic problem that's causing those things to happen. Because invariably, when people fix things like that, they will come back again. And they'll come back again because the reason why they were occurring was never addressed. And that's what understanding the body from a system standpoint does, is it fixes all of the whys behind why things are happening. Okay. And if you do that, you fix your pain. So I see the body more like this. I look at how we walk, how we bend over, how we sit, how we stand. It just makes intuitive sense that how you're using your body has a lot to do with why you're having pain. But how many of your practitioners have looked deeply at how you use your body? And I'm just astonished, patient after patient is just like, no one's ever looked at me like this before. And this is why they're still in pain up until that point. Okay, so if you've been struggling, this is probably why. All right. So we're going to do one final test so you can get what I'm talking about. So we're just going to have you stand up, and I'm going to ask you to put your hand right in the small of your back here. And make sure your fingers and palm are on both sides of the muscles. If you have balance issues, I just want you to hold on to a chair or table or wall or something like that. But all we're going to do is we're going to just raise one foot and then raise the other foot and kind of walk in place. And what you'll find, you'll feel that your back muscles are changing, right? One side tightens, one side loosens as you move your legs up and down, all right? This is showing you that how you're walking has a lot to do with why you're having back or sciatic pain. And if you raise one arm up overhead like this, you'll also feel your back muscles changing, right? Same over here, okay? You can do it again and again, and you'll find that there's a reciprocal aspect of how our body is supposed to work, and how we walk and move is critical to what the forces are that are acting on our spine and pelvis. And this is why there's so much chronic pain in the world. It doesn't need to be this way. Okay, the last thing I want to talk about are leg length discrepancies, because can I see a show of hands of people who have been told that they have a leg length discrepancy, right? And that is likely one of the things that are causing their pain. Yeah, a lot of people. Okay, you can put your hands back down. Thank you. And so let's get to the bottom of this. So my guess is that those of you who raised your hands and were told that you have a leg length discrepancy, that if you took a picture of your spine, you would find that you have a crease on one side versus the other, and that one side of your pelvis is higher than the other. And that's what people are basing the idea of whether you have a leg length discrepancy on. They're assuming that because you have a higher pelvis on one side, that you must have a longer leg on that side. That couldn't be further than the truth, from the truth. All right. In the 25 years I've been working with people, probably I can count on one hand the number of true leg length discrepancies I've ever seen. But would need a calculator to enumerate all the patients who have come into our clinic and said, oh, I have a leg length discrepancy, that's why I have pain. No, it wasn't why they had pain. It was because of how they're using their body, which is what is causing the side bending problem. All right. So there's confusion about this. So if you look at, I'm going to take the screen down a little bit again. So you can see that this side of the pelvis over here is higher than this side. All right. And this is what people are basing, oh, this must be a longer leg. No, what happens is that there are compensations. If you just look at here, we've got a hip joint, a knee joint, an ankle joint, and then 26 bones in the foot to account for our leg length. All right. So many sources of error that can arise in there. All right. The way I typically measure leg length this is called the greater trochanter. It's the little tip of the hip bone here, all the way down to this outer ankle bone. That way we only have one joint. And if you measure just the leg, you'll find that you do not have a leg length discrepancy. If you have a pelvis that's higher on one side than the other, it's because of compensations that are occurring in your body because of how you're using your body. And those compensations are what's causing your pain, not a leg length. I get rid of so many heel lifts in people. And it's so easy. This is so easy to fix. I'm telling you, 5 minutes, we can fix this. All right. So, and then I have people throw away their heel lifts and they feel better, not because they threw away the heel lifts, but because we corrected the uneven pelvis issue. We truly corrected it. Didn't just stuff something up in there to make it look like it's corrected. Okay. That's where the confusion is coming from with leg length discrepancies. I feel it's one of the biggest myths in orthopedic medicine is the fact that these things exist so frequently. Okay. So, hopefully this is new information for you and you're doing okay with it. All righty. So I call this a system solution because we're looking at the body as a system, right? And as opposed to component thinking, where we're looking at little things and trying to fix little things in the body without understanding how the larger picture is feeding into that stress at that particular level or whatever's happening there. So the benefits of the system solution is that you get very rapid results like Carol, the swimmer, or that other woman in 7 visits, 90% better, even though her whole body was contorted like that. We fix everything because everything matters. And the nice thing is that you, the patient, are in control because it's you fixing you. It's not me fixing you. If you fix you, you know how to do it for the rest of your life and you know exactly what to do. And that's the beauty of it. And because you can fix you, the pain doesn't come back because you'll notice when you're not doing something right again, like walking. All right. So that's the benefits of thinking of things from a systems standpoint. And I'll tell you, I've trained lots of physical therapists at my clinic, in this approach, none of them had ever been introduced to any of these ideas before. None of them in PT school, in CEU courses, nobody. This was all completely new to them. But once, and this was the interesting thing is, they would often, I would ask them, what's the most fearful area of the body for you to treat? Almost everyone would say back pain. That's the most mysterious thing, or neck pain and headaches or something like this. But after they learn this system, those areas become fun because now they understand exactly what's going on. And this is the beauty of this technique and this approach, is that it is so simple. And it's beautiful in its simplicity. It's hard for you to really understand that it's simple because you've been seen by practitioners and they've built all of this complexity into what is the problem. But the problem is so much simpler than you probably could ever imagine. All right, so it's so simple that someone can read one of my books and solve their pain. So that's how simple it is. All right. And I'll tell you, I haven't looked at that. I wrote that in 2015, and I haven't looked at it until maybe 5 months ago again. And I hadn't realized it has a ton of exercises in there. And I'm amazed that anyone can solve their pain using this because there's just so much to do in there. So I've really simplified things. So since I've written my books, I've published my first one in 2009. I've had lots of Skype sessions and Zoom sessions with people over the years. And I saw what my books were missing because they were calling me because they read my books. They got some success, but they weren't quite where they needed to be. And so I saw what was missing in my books. And then I have had my clinic and I saw the patterns of issues that were occurring that people, needed to see. And I started looking at people. It's as if there were patterns, like everyone was having a similar pattern. It would manifest as different areas of pain or different types of problems on an MRI or X-ray, but it was the same pattern. And so we fixed the same pattern in everyone, and all of their pain went away, whether they had stenosis or disc bulges or degenerative disc disease or sciatic pain or SI joint pain or whatever. And so that helped me realize that this is even simpler than I originally thought. So I've taken a lot of the guesswork out of this for you. And so I've created a downloadable program that fixes the patterns of issues causing pain. All right. And there's a DVD for those of you who like the DVD. And if you want to see what it looks like in the program, I'll be happy to show you. If you, in the Q&A session, you want to see, hey, Rick, what's inside of this thing? I'll be happy to take you through that. So just ask. All right. I couldn't say that I understand the body as a system if I didn't have a program for all the areas of the body. So if it just was back, then something would be missing. So anyway, I've got programs for all over the body. So I answer all questions. I guide people. I go as deeply as anyone needs me to go. And, I help you get the answers that you need. So it's not like you're just out on your own now. All right. I want you to get better. And I think you can get better. You just need better information. And I think I can provide that for you. Okay. And then for the first 11 people, if you enter this promo code BPW472, you can get the free DVD instead of having to pay for that if you want the DVD. And you just you can see this little thing down here, www.fixbackpainwebinar.com, and enter that code. And I'll show you how right here. Let's show you what that looks like. Alan, can you turn on the screen share for me?
1 second. Might have to make you host to do it.
Yeah.
Let me pull this out here and make host. That should work.
Okay. I think this is it. All right. So if you go to fixbackpainwebinar.com, you're going to come to this page. And here's where you enter the code BP. Oh, you can see over here to the right here, the price is $47 and the shipping and handling for the DVD and all that kind of stuff So BP, let's do the caps just in case that matters. BPW 472, and we hit apply. And you can see that takes off the DVD shipping and handling and even $1 or so more. Now you may have taxes, I'm not sure, but anyway, I've taken care of that for you. If you want to get the rest of the programs, you can click here and you'll pay an additional $97 for the rest of the other 4 programs together. So it's up to you. If you have problems from head to toe and want everything, then this might be a good call for you. And then you just, fill out this stuff. All right, so that's all I wanted to show you there. So let's go back to here. And
did you want to go into the members area while you're here?
If someone wants me to, I will.
Okay.
So if someone wants, you can just ask, and I'm happy to take you there. So, but I want to make sure I get people's questions answered. So, Alan, why don't you, if you have a question you'd like to ask, there's a little function at the bottom of your Zoom panel where you can raise your hand. I think it says reactions. So just raise your hand if you have a question, and I will answer those for you. And Alan will call you up.
At the moment, no, I've got 2 people joining though. So let's see.
Everything is crystal clear. Well,
Looks
that
like
is amazing. No questions whatsoever. Incredible.
Oh, 2 hands coming up. Let's see. I've
Okay.
got the first one was Oliver, and then the second one is Nancy.
Nancy. Okay.
So
Great.
Oliver, go ahead and unmute.
Okay, good. All right. Are we doing Oliver?
Yeah, Oliver, then Nancy, then Leanne.
Okay. Hey, Oliver, can you hear me?
Yeah, Rick, I can hear you. Can you hear me?
Yeah. Do you want to keep your camera off, or do you want to turn it on?
I can turn it on. It's no big deal.
Okay. It's nice to see who I'm talking to.
Yeah, definitely. I heard about you through Funk Robert. I'm in his program, and I listened to the podcast. So I was like, with my back, I'll try anything. So, so I tried your program, and I think I've had access ever since last Monday. And the pain kind of comes and goes. So my question is, how long after doing this would you find the confidence to be able to do burpees again?
Oh, burpees. Oh gosh. Okay. So let me ask, so that's a really good question. Burpees are particularly aggressive for an extension problem because that back arches, right?
Right.
Yeah. And then if you have a larger belly, that's even more force pulling it into that arch. So what I would do is maybe a modified burpee first, like on a weight bench. You know what I'm saying? So it's off the ground a little bit to see how you're doing. But really, I think for me, if you were my patient, Oliver, and you wanted to get back into burpees, I would make sure that you are 75% better with your pain before starting something really advanced like that. Because the burpee is such a fast movement and it's involving so much of the body. If you don't have decent control and have turned on certain, like your butt muscles, or did you find that your thigh muscles were tight, Oliver, when you did that TFL stretch on the table?
No.
They weren't tight.
No.
Okay. How was your butt working well?
Yeah, it works pretty good. I think my issue is the side bend issue.
Side bending. Okay.
Yeah.
Got it. All right. So, so you've been practicing the reaching while walking.
Right.
Right. Okay. Now, so was your pain unilateral when you started?
No, it's more center to the left.
Center, and was your side bending problem on the left too?
Yes, it is. Okay.
All right. All right. So what the side bending problem is showing you is that you have a problem somewhere in your left leg. All right. An old problem, like, maybe you had multiple sprained ankles in your left foot, or a knee issue or a hip issue, something like that is contributing to the existence of that side bending problem. Does that ring true to you? Do you have any old injuries like that?
Yeah, when I was a kid, I played basketball and I used to sprain my ankle all the time.
Okay. So did you come across the foot taping technique?
I did. I saw that, but I didn't do it.
Okay. If you have multiple ankle sprains, I would go with the foot. ankle taping technique to see if that can stabilize that weak point in you. Because what's going to happen is, because of your history of ankle issues on the left side, that left gluteal muscle is not going to turn on as well. And so you're going to get more collapse on the left side.
Okay.
And then the waist muscles contract harder to pull up that left side. All right. So even though that reaching while walking will temporarily correct it, you have probably an older, deeper issue that you need to get into with that ankle. For the time being, let's just try taping that for a few days and see if that stabilizes your body enough that you feel confident to do burpees again.
Okay.
All right. And if it does, then that tells you, oh, I've got to address this ankle. This is the source of my problem.
Okay.
Does that make sense?
It does. Thank you. I appreciate it.
Oh, my pleasure. Thank you, Oliver. Okay.
Next,
Nancy.
we have Nancy.
All right. Hi, Nancy.
Hi.
Thanks for being so patient.
Oh, sure. You're worth
Yeah.
waiting for.
Oh.
So I've had your DVDs and books for a while, but with I test 1, test 2, test 3, I filled them all. Anyways, I wanted to ask you a question about the walking. So when you walk, should your heel hit the ground first or the middle of your foot? I'm trying to get a good idea of when I walk. Am I doing a long enough gait, or am I, how can I start to get some better butt muscle contraction going?
Yeah. So this is a great question, Nancy. And by the way, you didn't fail those tests. They illuminated what the problem was for you.
Perfect. Thanks for putting it in a more positive point of view.
It is a positive thing
that.
because now you understand what's going on, right?
Exactly. Okay. I know what the source is. Yeah.
Yes. Yeah. So
exactly.
Let's get to your walking. This is a really common one for walking. So where you're landing on your foot is not critical to getting the gluteal muscles to turn on.
Okay.
All right? What the problem is what is turning off the butt muscles is that you are likely locking your knees when you walk. Perhaps your foot is too far out in front of you. And so when the foot is in front of the body, the knee tends to lock, and then that turns off the butt muscle. There's no reason for the butt muscle to turn on because all your weight's on the back foot instead of the front foot. So what you have to do is you have to learn to let your body come forward with that advancing foot. And when you do that, you'll find that your knee unlocks naturally and your foot will land however it lands, but your butt will start to turn on at that point.
Oh, okay. So it's if you're standing and you just bend your knees a little, it unlocks it. So you do the same thing when you're walking.
Yes.
Oh, that's great.
So simple. Yeah. So what I would say, are you a tall person, Nancy?
No, I'm about 5'4.5".
Okay. So what I would say is I would take shorter strides initially.
Okay.
Because right now your pelvis doesn't know how to catch up to that foot that's advancing. Because you've trained it to stay behind it. All right. So it needs the normal stride length is too long to change it. So I would start with half the distance of your stride and force your body to come forward with that advancing foot. Right. And it doesn't have to be this leaning. It doesn't have to be this kind of leaning over kind of thing. Right. You can be tall and come forward with that foot. All right.
Okay.
And then once you practice that, then you can start straight lengthening your strides again, and you'll resume your normal walking pace and pattern, but with the change that your body's coming forward with the advancing foot.
That sounds doable, and that sounds wonderful. And I feel like I need to undo what I've been doing, and it's easy from what you've just described to me. So thank you so much.
Oh, my pleasure, Nancy. Yeah, you should see some big changes with that.
Yeah. All right. Thank you so much for doing this tonight.
Oh, sure.
And, I think every time you do it, I try to get on, and I think you just, it's just wonderful information and knowledge. And just one other quick thing.
Oh, sure.
you sold your store here in Denver where I live, but
Yeah.
can we feel that if we go in there, those people that you trained can give us the expertise that we would get if you were there? Do you feel like we could walk in and they could help us if we wanted to work with someone one-on-one instead of just with your DVD program and your books?
Yeah, the people I've trained who are there, you could certainly do that.
Wonderful. Okay.
Yeah. But feel free to shoot me an email about that, Nancy, if you like. Okay.
Okay.
All right.
All right. Thank you so much for your time.
Well, my pleasure. Yeah, good seeing you.
Okay, good to see you too.
All right, bye-bye.
Bye.
Okay, Rick, now we have Leanne. Ask her to unmute.
Hi, Leanne. You've been so patient. Thank you. Sorry for the
wait. Hi, nice to see you. Nice to meet
too.
you. I'm in Portland, Oregon.
Oh, good for you.
Yeah, it's I grew up in Denver though, so
oh, okay.
Yeah. I have a little bit of a complicated pain pattern.
Okay.
I I do have back pain, but I have mostly right foot, ankle, inner thigh, and groin pain, and then top of the right crest. And I am at a loss as far as figuring out. My mobility has just in the last 2.5 years gone way downhill, and I've been to so many physical therapists and back surgeons, and I can't seem to get any understanding of what's going on.
Okay.
And so I know this is, sorry, go ahead.
Go ahead. Go ahead.
I was going to say, the latest is that I've seen a foot surgeon who I really like because my foot does hurt a lot. And he's proposing the big toe fusion. So anyway, yeah, I've had back surgery. That didn't help. Yeah.
You are exactly the kind of person I love to work with.
Oh,
all
boy.
Right.
Okay.
So here, I mean, of course, I don't know any of these things I'm about to tell you, but this is what your pattern is fitting this type of diagnosis. Okay. That I'm going to explain to you.
Okay.
So one is when we did the walking test on this today, did your butt turn on?
No.
No. All right. So what I suspect that you have is something called an anterior femoral glide syndrome. I'm going to show you what that is. This is my trusty skeleton. So when we walk, the hip bone in the hip socket should just be pivoting in the hip socket like this. But I'm going to bet that because your butt isn't turning on, that your hip bone is migrating forward when you're walking. And so it's careening around in that hip joint, and that's what causes groin pain. All right. It's a common complaint with an anterior femoral glide syndrome issue.
Okay.
All right. Has anyone tested that for you?
No.
No. This is what frustrates me to no end. It's so common. All right. So it's very easily solved. All right. So have you gotten any of the programs?
I'm a newbie. I got your book on your back pain book, and then a friend, she had your other programs. So
okay.
Yeah.
I'm going to recommend if you want to do any of my downloadable ones, it would be the hip pain program.
Not the foot or back.
The back is likely coming from the hip.
Okay.
Dysfunction. So if we solve the hip, and that will also include this whole chain, I think your back will probably resolve. And that's why the back surgery didn't stick, is because you haven't resolved the reason that you're having back pain, which is all of this.
Well, I mean, it's mostly foot pain.
Yeah, right. But you've also got inner thigh and groin pain too.
Yes,
That
yes.
indicates that there's a problem with your tracking in your hip joint.
Okay.
All right.
Okay.
So it's not only foot pain. The foot may be the thing that turned off the butt muscle on the left side. I don't know. Or it could be that because the butt muscle isn't controlling the thigh bone, then it's not controlling the rest of the leg either. And now your foot's paying the price for that too.
Okay.
It can go either way.
Okay.
So, but anyway, and I don't want to sound like I'm just trying to sell something to you, but that hip pain program will help you strengthen this gluteal muscle and teach you how to walk correctly.
Okay.
But it also has recommendations to tape the foot in a better position to support it in a manner that it needs in order to function better.
Okay.
All right. And it's my own taping technique I developed for just this systemic type of problem. No one else does that. So it's completely unique. And I can guarantee no one's ever done it with you before. But it is a miracle worker for a lot of people with foot, knee, hip issues. When we tape their foot, suddenly everything is aligned better and they see, oh my gosh, okay, this is how it's supposed to be.
Okay.
So that's what I would recommend. But my guess is that, yes, you do have two areas. We need to address this foot. And by the way, do you have a history of plantar fasciitis?
No, I had a bunion removed in 2014.
Do you have tight calves?
I'm sorry?
Do you have tight calves?
Yeah, for sure.
Okay. Tight calves are a problem, and I show you how to solve that in that program too. All right.
Okay.
They are creating excessive strain into the foot.
Okay.
Because the body is trying to advance over the foot, but the calf muscles are too tight to allow that to happen easily.
Okay.
And so the force of the body going forward has to go someplace. It either goes down and through the foot bones or it goes back up into the knee and the hip.
Okay.
All right. And so the taping, what that will do is keep the strain, the excessive strain from happening in the foot. But ultimately, you have to solve this calf issue.
Okay.
All right. That's what's putting too much pressure into the foot in the first place.
Okay.
All right. All of that is covered in that, I think, hip pain program.
Hip pain. Okay. Thank you.
All right. It's simpler than you think, Leanne. Don't give up because you can solve this. All right.
Okay.
You can. Yeah.
Thanks.
So, and it'll be simpler than you think and faster.
Great.
All righty. Okay. Thank you.
All right. So, Rick, we have one other question actually, we have two other questions. One of them is by Jim. Jim, I don't know if you want to unmute yourself, but the first part of it, it's a longer question. I'll just read the first part. It says, is bow-leggedness that's deemed genetic from one's generation going back to one's parent and their parent worth correcting somehow?
Jim, do you mean correcting surgically or correcting biomechanically? Are you still there, Jim?
He says biomechanical. It's very loud where he is. He's going to stay on mute. He says biomechanically.
Okay. So I have found if it is a true bow-leggedness from the shape of your bone, it's very hard to correct that biomechanically, Jim. You know, what happens is the more that the lower leg bows out, the more that the foot collapses in to compensate for that. Because the leg is bowing out, the foot has to collapse in because otherwise the whole foot would turn on its side. And so you get this whole stress to the ankle. And then that also creates a lot of havoc at the knee joint because it's kind of caught in the middle. It's a difficult thing. To be honest, Jim, I haven't found any real biomechanical solutions to fixing bow-leggedness. We can temporarily unload the joints that are experiencing pain from the bow-leggedness, but I haven't found a way to stop or, you know, of course, reverse that bow-leggedness because it is the shape of a bone. And what you're telling me is this is a genetic issue that you've got from your parents, that your bones are just shaped that way. And I find that most of these people who have this end up having a knee replacement surgery of some sort, which almost eliminates that bow-leggedness and is a miracle for a lot of people. I don't know if you're at that point yet, but you know, if you're having various spotty aches and pains, then, I would try, taping up the foot like I was talking with Leanne about. That will offset that bow-leggedness force that's driving the foot down. That could cause plantar fasciitis. I don't know where your pain is.
He said he's not close to that point yet.
Oh, okay, great. Then what I would do, Jim, is just shore up the whole system, and like make sure your butt is turning on when you're walking. Make sure your calves are not excessively tight, because that's going to exacerbate the effects of the bow-leggedness. You could try the little taping technique that I have in my video. And if that helps, then maybe it would be worthwhile to get a pair of aggressive shoe orthotics. And if you email me, I'll tell you the company of the shoe orthotics that I like to use that I think are I think the best. And so that's what I would do is, like the testing that we did today. If you have I would fix all of those things. If you have an extension problem, if you have a side bending problem, and just keep shoring up your body and make it as perfect as possible in light of the bow-leggedness. And once it gets to a point where, something has to be done, at least you'll know that your body is humming along perfectly in spite of this genetic condition. So that would be my general advice. I don't know if I even answered your question, but I hope I did. Things aren't hopeless. There's a lot you can do until that point happens, offsetting all of these biomechanical compensations that will occur because of that.
Okay, he's saying another question. Does the bow-leggedness come from the hip position, possibly?
Well, it's hard for me to answer that because I haven't worked with you. Typically, I don't see that as the issue. It's just a genetic issue about the shape of the lower leg bone, the tibia. That's the problem. It's not, bow-leggedness typically doesn't occur because of a hip issue.
Okay, so let me see. He said one more thing here. He says, okay, thank you, Rick. Perfect.
Yeah, sure, Jim. Thanks for asking.
All right, so I have another question here by Maurice. I'll read it and then she can unmute. So Maurice says, I have Achilles pain and low back pain on the same side, left. I just finished the 12 sessions of shock therapy with a physiotherapist. A little relief, but not much. I played tennis, which does not help my problem. Any tips?
Yeah, lots of tips. So I hate to sound like a broken record. Was it Charisse?
Maurice, M-A-R-I-S-E.
Okay, so I hate to sound like a broken record, Maurice, but foot and ankle pain is just like I was telling Leanne. It's usually due to excessively tight calf muscle. And I have a unique taping technique to offset that tightness of the calf muscle until it's loosened up appropriately to stop putting excessive stress into the foot. And the back pain may be coming because you're compensating for that foot pain. I'm not sure which came first, likely the foot pain, I'm going to guess. But anyway, once you solve the foot pain, then you'll probably stop that side bending pattern happening on your left back pain too. And that will help that. But likely, if you've been hobbling on that foot for a little while, your butt muscle has shut off more on that left side than the right side. And that's one of the things that's contributing to that left-sided back pain. It's because you have less stability on that side too.
She said the back pain came first.
Back pain came first. And do you have was your foot pain an old injury? Did you have an old foot injury prior to the back pain, or knee or hip?
She says no.
No. Okay. Well, if the back pain came first and it's a unilateral back pain and it happens to be on the same side as the foot pain, I just have to assume that the foot is coming first, because it's unusual for the pain to go from the back down to the foot, because the back is responding to the whole lower leg system. So if the lower leg system is perfect, we shouldn't have that left side, that left back pain. So, that's my 2 cents on it, is that in order to solve that back pain, even though it came before the foot pain, you're going to have to solve that foot pain. Because if you can't walk correctly, that back pain is just going to continue being hammered. And after you've solved it, let's say that you solve the foot issue and it corrects 50% of your back pain. Okay, well, we've taken care of 50% of the problem. Now the other 50% you can address through fixing the pelvis or the back issues themselves. But I feel, as from what my experience, as long as you have a foot issue, it's going to constantly be feeding up the chain to that back. No matter how perfect you make everything up there, you've got to solve that foot.
She said, okay, thank you.
Yeah, sure.
All right, so I don't think I see anything else here. No other hands raised. Oh, Allison is saying, what do you think of the Feldenkrais method for back pain?
Yeah, Feldenkrais is great. So, it's interesting. So you remember me talking about Thomas Hanna. Legend has it that he's the one who brought Feldenkrais to the United States. And Thomas Hanna studied under Feldenkrais. But Feldenkrais didn't address movement enough. And so that's what Thomas Hanna developed his movement, his Hanna somatics off of, is to introduce more movement, like voluntary movement, into the equation. But Feldenkrais does a great job of solving a lot of pain. It will help unlock things. And this is also, there's always going to be pros and cons of everything. And this was one of the things that I found about Hanna somatics, is that they didn't understand biomechanics. They didn't take that into part of the equation. They did movement beautifully, but they didn't understand biomechanics. Just like Dr. Saarman understood biomechanics, but she didn't understand fascial issues and neurological reflex patterns as they fed into that. So, Feldenkrais is great. Hanna somatics is great. Dr. Saarman is great. And some people need all of these things to come together to solve their pain. And some people only need a small part of one of these things to solve their pain because of where they are in how their body works. You don't need to have, and that's why so much, of these other treatments work well, is because the issues aren't as deep at that point. When simple things can solve problems like dry needling or manipulation, and that solves it for a long time, it means that you're pretty close to your solution already. It's when Feldenkrais doesn't work and physical therapy doesn't work and Hanna somatics doesn't work and massage doesn't work and surgery doesn't work. When all of these things start failing, it means you have a deeper problem that you need to pull all of this together into. You need a more cohesive solution. So I would say try Feldenkrais. If it works for you, then there's your answer. It works. There's a lot of great things happening in Feldenkrais.
Okay, and Leanne asks, well, Allison says thank you, of course. And Leanne says, what do you think of the Egoscue method?
Same thing. I mean, there's a million methods out there. So they've all helped somebody because they wouldn't be around if they didn't. And so again, if your problem is such that the Egoscue method works, then that was your key, right? I work with people where nothing has worked, and that's what they need. Yeah. So that's why I just have my patient population. I've had to look deeper, and so those are the solutions that I found for people.
Okay, so I don't think we have any more questions. I'm looking for hands, looking for chat. I think that's it.
All right.
Oh, Christina.
Christina, I knew you had a question.
Let's see. There she is. Where is she? She should be coming up soon.
Your mute button is still on.
Okay.
There you go.
It's really great to see you, Rick.
It's great to see you too.
I wanted to say thank you before we ended the call, because what you told me last time about my knee, it helped so much.
Oh, great.
I'm like 90% better.
Oh, I'm so happy for you. That's great.
Yeah. I can go up the stairs. I can get in and out of the car. I still have a tiny little bit to go, but it's been like night and day. And I just wanted to say thank you.
Oh, my pleasure. That's wonderful. Yeah, you look great. You look very happy. Yeah,
I am happy. Well, who wouldn't be?
Yeah. All right, I'm happy for you, and thank you for that.
Okay.
Okay.
All right, good. So let's see. I think I just let somebody in. I don't know if they have a question or not. Who did I let in just recently? Well, at the moment, there's no questions.
Okay, everyone, it's been over an hour. I don't want to bore you to death, but that's about all I have to say. If you don't have any questions, again, thank you for joining me. I hope this gave you some answers, and if not answers, at least a direction to start looking in to solve your pain. I firmly believe you can solve your pain. So you just need the right information. So thank you for joining me. And if you end up joining the, buying one of my products, I'll see you on the other side in our Q&A sessions. All right. All right. Thank you for
Rick,
joining.
Do you have any more of these sessions planned?
For people who have purchased my products, yes.
Yes.
So for those who haven't, I may do a few more webinars, but not very many. It won't be, as many.
Okay.
Yeah. All right. Good question. All right, everyone. Have a great night, and thanks for joining me.
Thanks so much.
All right. Thanks, everyone.
Bye-bye.